Today, we're going to be talking about herniated lumbar discs, a very common problem that many people are afflicted with. I'm going to have help today from my close friend, Susan Keith. I'm going to discuss with Susan some of the symptoms and findings related to a herniated lumbar disc. And just as I would explain it to a patient who came into the office who has questions, I'm going to ask Susan to have questions as they arise. And so thanks for coming and joining me in this.
Oh, sure. I have one question right away, right off the bat.
You bet. Go right ahead.
I don't know whether to call him Dr. Kornel or Eddie or...
I'm Eddie to you, right?
You're Eddie to me.
Right?
Okay, so you're Eddie.
Yes.
He's a good Eddie.
That's my nickname. My full name, Ezreal Edward Kornel.
He's showing off now.
Edward, my middle name, Ed or Eddie. My close friends, like you, call me Eddie.
That's right.
I was actually named after my grandfather, who was also a physician.
What kind?
He was a general internist.
Oh.
I never got to know him. He died just after the war. He was in Poland. But he was apparently an excellent physician. So here we are we're going to talk in this segment about herniated lumbar discs.
Herniated.
So first of all,
what does herniated mean?
That's a great question. So you hear about slip discs, you hear about ruptured discs, you hear about herniated discs. They're all sort of synonymous.
And they're all hurt a lot.
Well, they may or may not. Sometimes people don't even know that they have a herniated disc. So when we treat patients, it's not just about what they have on an MRI, it's about what symptoms they have caused by that. So your question's a great one. What is a herniated disc? What do we mean by that? Well, first of all, you have to understand what the disc is, right? The disc is the cushion between the vertebrae of the spine that holds the spine together.
What's the cushion made of? The spine is bone, right? And there's a cushion.
The spine is bone, and the cushion is made up of fibrous material and a protein gel combined with water. And I'm going to show you a model of that.
This is the real deal. Okay.
So you had a great question, first of all, about what's a herniated disc or what's a disc.
Yeah.
And what's it made of? Well, here's the lumbar spine. These are the bones, of course, and these are the vertebral bodies. There's the supporting structure of the spine, the backbone of the spine.
Vertebral mean?
Vertebral, these are the vertebrae. Each one of these segments is a vertebra.
So vertebral.
And so the vertebrae, each vertebrae has a pair of joints that attaches to the other vertebrae. Ligaments hold the joints together. And it has a roof of the spine called the lamina. It has this portion which sticks out called the spinous processes that the muscles attach to, that then the muscles pull and allow movement. The nerves run through the spinal canal. And then the discs are the cushions that sit between the vertebrae so that bone isn't against bone.
And they really do kind of like a Tempur-Pedic mattress?
Yes, they compress and re-expand. And they have a central nucleus that is, it's sort of like a soft-boiled egg or a chewed gum. It has a soft center that is liquidy, gel-like, can compress and re-expand with a very thick outer ring that holds it all together. As a disc is damaged or degenerates from use, it becomes more like a hard-boiled egg. The inside loses its watery content. It becomes tougher. In fact, it looks almost like crab meat. And so when you compress it, it doesn't re-expand. And eventually it pushes out against the outer lining of the disc, that nucleus fibrosus that keeps it together. And that weakens.
You mean it kind of slips out to the side?
The inner portion can slip out anywhere along the disc.
Oh, right through the
But when it starts to push out, it can bulge out. It doesn't have to break through this outer lining. It can just bulge out. So then you have a bulging disc. Some people do refer to it as a herniated disc because when the disc is no longer in its confined space, when that center portion is no longer in that confined space, it's generically called a herniated disc. There are different degrees of herniation. So when it becomes more profound, then it becomes a ruptured or extruded disc, so that the piece can actually break through the outer lining. On the other side of the outer lining in the canal is a ligament called the posterior longitudinal ligament. Inside of that is the spinal canal with the nerves running through, and the nerves come out through these openings or go in through these openings.
That's what
to
makes
the
a
legs.
pinched nerve?
When these nerves are compressed, exactly, that becomes a pinched nerve or sciatica. So if a piece of disc protrudes out, it can be still covered with this lining, or it can be actually breaking out through all the linings and pushing directly on the nerve with no membrane in between, in which case it's a sequestered disc.
So, Eddie, it's not the disc that hurts itself, it's the fact that it pushes against the nerve, and then the nerve is what we feel if we have that happen.
If we have sciatica, it's because the nerve is being compressed. The discs themselves can at times cause pain. But that's a very complex issue because it's interesting. Some people have very degenerated discs and have no significant back pain. Others have a bit of degeneration and can have a great deal of back pain. So there are a lot of aspects that we have to assess when deciding what kind of treatment to give someone with a problem with a disc. But in the case of an extruded disc, you have sciatica, which means you get compression of one of the nerves, and that nerve forms the bigger nerve that runs down the leg. So when the sciatic nerve, which is made up of several different nerves, is compressed, then you get pain down the leg. Along with that, you can get numbness and tingling, and you can get weakness. Sometimes you have one more than the other, so you may have more weakness than pain or numbness. You may have more numbness, or you may have pain without any of the other features. You can't predict for any given individual. It's very much dependent on their anatomy and physiology as to what will be the predominant symptom. The nerves that come out of here are called the roots. And when a nerve root is compressed, it's called a radiculopathy. When the nerve doesn't function properly, it's called a radiculopathy. So these nerves tend to go to specific muscle groups. So the L4 nerve root goes to the quadriceps, and when you have weakness of the quadriceps, you have difficulty extending your leg. Your knee can feel weak, and sometimes if it's particularly profound, your leg can give out. When you have an L5 radiculopathy, then that's the nerve that goes to the foot to elevate the foot. And that's when people get a foot drop. When that nerve isn't working, you get a foot drop, and that can be a profound problem because if you can't lift your foot, you tend to trip over your foot.
Oh, boy.
So if someone develops a complete foot drop where they can't lift at all due to a herniated disc, that becomes an emergency. Because if you don't relieve that pressure on the nerve quickly, that foot drop can sometimes become permanent. Now, there are lots of times when people have a weakness of the foot and it isn't a complete foot drop. Then you can take more time because sometimes that disc herniation will recede. In fact, most of the time, there is some reduction in the size of the herniation. There's water in that disc herniation, and as that water gets dissipated, the size of the herniation decreases.
Right.
Also, the body has a way of absorbing things that shouldn't be there. So it's able to absorb a portion of that disc herniation. The disc cannot slip back into place. Just like you can't make a hard-boiled egg into a soft-boiled egg, you cannot make a disc that has an extruded piece back into a healthy, normal disc again.
But you can live with it slightly out?
Oh, most people do. The majority of people do indeed recover from a disc herniation and can function normally again. The majority do not require surgery. It's that small percentage of people who have a fragment of disc that doesn't resolve or that continues to, their anatomy is such that that fragment continues to irritate and compress the nerve.
So that's when they need to come to you.
That's when they need surgery. Well, they come to me to ask whether or not surgery is the appropriate treatment.
And if you don't think it's surgery, what do you tell them to do?
Great question. Well, often people have already been here, who come here have already tried something.
Yeah.
But
you mean like yoga or chiropractic or
primarily
drugs?
Chiropractic, physical therapy, and medications. But it's also dependent on what type of therapy they've had, who they've seen, who's been treating them. Often people will come after physical therapy or chiropractic and they've gone for 1 or 2 sessions and they say, oh, it didn't help. But that's probably not enough. You need to go regularly for a protracted period of time so that you can strengthen muscles, you can realign your body, you can give the inflammation time to resolve. And you need to go to someone who knows what they're doing.
Right.
Not everyone has the same degree of knowledge. Some physical therapists are better at dealing with knees or hips. So you want a physical therapist who understands the anatomy of the spine. You want to go to a chiropractor, in my opinion, who is very adept at problems related directly to compression of nerves in the spine rather than to a more holistic approach. Though there's a value to a holistic approach.
Yeah.
When you have a herniated disc, you want someone who really is understanding of the neurophysiology.
Do they use those new machines that I've read about, the chiropractic? You know, there's like some sort of machine
they
that
have
use
these
rather than just...
they have these distraction tables. They're supposed to relieve pressure on the discs and relax muscles as well. We'll have to have a chiropractor on to address that fully.
That would be a good idea.
But I can tell you that that machine can't make a disc go back into place
Right.
either.
Only you.
Well, I can't make it go back into place. I can
You
only
can't?
remove the piece that is compressing the nerve. You have to remove it.
So you remove it and then you can put something else in there?
Well, we only put something else in there if we're going to remove the entire disc.
Oh.
But we don't have to remove the entire disc most
Sometimes
of the
you
time.
take out, like as if you were to splinter, but bigger deal.
Well, right, in a sense. We're plucking out that piece of disc that is now non-functional and not in the right position.
Is that what you call a minimally invasive surgery?
Well, that's the type of technique. There are different techniques to get to that fragment, to remove it. It's all about getting into the spine, getting into that, and getting that fragment out. The way that I like to do it, through a minimal access approach, what I refer to as an endoscopic approach, because we're operating through a tube, is to go through a very small incision, about a 2 centimeter incision or less, and without cutting any muscle away, go directly into the spine, right in this little opening here. You have to, often because the vertebrae, the lamina can overlap so that you don't actually have a space there that you can get through.
So that's what you kind of...
Then you have to shave a tiny bit of the bone off sometimes.
Wow.
And then we get into that space and we remove the fragment of disc. Sometimes we don't have to go into the spine at all. If the disc herniation is to the side here, then I can come right through the tube, right through here, and then I'm not entering the spine at all. I don't have to remove any bone. I don't have to remove any ligament within the spinal canal. I'm just removing that piece of disc that's pushing on the nerve. It's very gratifying because when the pressure on the nerve is released, then the pain most of the time resolves immediately. And most of the time the strength recovers immediately. When the S1 nerve root, by the way, is compressed, it goes to the back of the leg, and then you have difficulty pushing the foot down. It's not as debilitating as when you lose the ability to lift the foot, but certainly it can be debilitating as well.
So basically, Eddie, do you know when you should go? It isn't just from feeling like, you know, uneasy or restless leg or whatever. It's when you can't actually pick up your foot or your knee and it's really painful.
Well,
other than that, you could use all those other ways of just trying to maybe not sit so long or just keep moving. Or, I mean, how do you know the difference between when...
Well, there are two things. There are two things. One is when the weakness is so profound that you really have trouble making that muscle work. Then it is imperative that you seek medical information about whether you do need surgery or some other direct treatment. When your pain is so profound that you can no longer function normally, then you should seek treatment as well.
The last resort is operating.
But otherwise, you certainly can try a variety of modalities. It's best, though, rather than floundering, to go to someone who is an expert on the spine, whether it's a neurosurgeon, a neurologist, or a physiatrist. You should seek out medical attention from someone who is very familiar with these problems.
And they'd have to be able to, they'd have to take an MRI to be able, for the doctor to be able to
Make the diagnosis?
Make the evaluation?
Well, most of the time we can clinically make the diagnosis, and then we get the MRI and it confirms what our suspicions are.
You mean just by feeling it you can?
By examining you and by taking your history.
Oh.
So I generally have a very good idea of what the problem is before taking the MRI. But of course, nowadays we want a confirmation, and so we get an MRI, which shows us then the discs and the disc herniation.
And then when you get the disc, you can get. I've heard people. You tell people that they get out the next day.
People can leave the hospital the same day after surgery. Same day.
It's remarkable.
So most people do leave the same day.
Wow.
So we've discussed a lot, and you've
Yeah.
asked some great questions, and I think that people are going to have a pretty good understanding, because I think
it doesn't seem so scary. You know, it's always like, back.
Right.
No, oh no.
Well,
no.
it shouldn't be scary, because in fact, this surgery is very safe and very effective. When it's done, of course, by someone who's got experience doing the surgery, it is indeed a very safe operation.
And I'm lucky I know you.
Well, hopefully you'll never need it.
I know, hopefully I'll never need it.
It's always better not to need any surgery.
Yeah, definitely.
Well, thank you so much for watching this episode of Lumbar Spine Disorders. I'm Dr. Ezrael Kornel, and we hope that you'll watch other educational episodes that we have.